就是我们这样子就可以了。好，那我就开始这样。如果有需要什么，我都在这一间。好，就里面敲门就可以了。
Ladies and gentlemen, welcome to Parallel Session 2C of the 2022 Global Health and Well. Program is going to start in 3 minutes. Please be seated, turn off your cell phone, and keep your mask on all the times. We offer simultaneous interpretation today, and the equipment is available at registration on the first floor. 各位现场的先生女士，大家好，大家午安，欢迎您来到台湾全球健康福祉论坛平行场次2C。好，那在这边呢，要提醒您，我们稍后的活动再过3分钟，马上就要正式开始喽。还有，请您不要忘记全程帮我们佩戴口罩，以及呢，我们今天活动也有为大家准备了翻译机，请您可以在1楼的接待处、报到处领取。I would also like to remind you that in the spirit of environment friendliness, the forum will not provide the physical copies of the program book. You can download the book by scanning the QR code on the back of your page. We thank you for your cooperation and understanding. 那也在这边呢，要提醒大家，秉持着我们环境友善的精神，所以我们这一次大会是不提供实体纸本的节目手册，欢迎您可以扫描您识别证背面的 QR code 来下载大会手册哦。好，那再次提醒您呢，我们的活动再过3分钟，马上就要正式开始了。And our program is going to start in 3 minutes. Thank you. Good afternoon, ladies and gentlemen. Once again, welcome to Parallel Session 2C of the 2022 Global Health and Welfare Forum in Taiwan. Parallel to Session 2C, beginning now, will be on the topic of paradigm shift to face the challenge of super-aged society in Taiwan. 好，再次欢迎各位现场所有的贵宾来到我们今天台湾全球健康福祉论坛平行场次2C。那我们这一场次的主题是因应台湾超高龄社会挑战的典范转移哦。And we are honored to have Professor Alan Minglun Shi, Distinguished Professor, School of Dentistry, National Yangming Jiao Tong University, ROC, to be our moderator today. 请大家以热情的掌声欢迎国立阳明交通大学牙医学院特聘教授许明伦特聘教授来担任我们主持人。再次热情掌声好吗？欢迎许教授 ，Welcome, Professor Shi.
Good afternoon, ladies and gentlemen. It is a great honor for me to host this session for the oral health care in this Global Health Forum. And my name is Alan Minglun Shi. I'm currently the president of Association for Dental Education, Asia Pacific, and the immediate past president of Southeast Asia Association for Dental Education. And I'm currently the president of Taiwan Association of Dental Education and the distinguished professor of School of Dentistry, National Yangming University. The percentage of people aged above 65 in Taiwan in 2021 is 17%. But it is roughly estimated that the population of age above 65 in Taiwan will reach 20% in 2025. So it is roughly estimated as 4.6 million. And So in 2025, each one of 4 people in Taiwan will be elderly. According to the definition of WHO, if the percentage of elderly with age above 65 is more than 20%, and then it is called super aged society. So with Taiwan, now we are approaching to face the challenge of super aged society. And there are 3 main issues for this society, for this super aged society. One will be the bacterial target therapy. It will be necessary for this to face the challenge of this super aged society. And the second is regarding to the reconstruction of oral health by tissue engineering. And the third is oral cancer. Oral cancer remains one of the most important issues for our oral health in Taiwan. So in this session, we invited 3 world well-known scholars from Hong Kong, from Japan, and also one from Taiwan. They will make a speech regarding to this topic respectively. And first, it is a great honor for me to introduce you the first speaker, Professor Jinghui Zheng. Professor Zheng is currently the Dean of School of Dentistry, Kaohsiung Medical University. And his research scope is mainly at the betel nut chewing, and oral cancer. Let's give a big hand to Professor Zheng.
Good afternoon, ladies and gentlemen. It is my great honor to present a topic about the paradigm shift to face the challenge of super-aged society in Taiwan, with special emphasis on the tooth root fractures that are popularly noted in the aged population. In Taiwan, the aged population has increased from 7% in 1993 to 14% in 2018, an aged society. And it has been estimated that the aged population will reach 20% in 2025 and become a super-aged society of Taiwan. In addition to the higher prevalence of various systemic diseases, the common oral health problems in the elderly include periodontal disease, dental caries, cervical abrasion, dental hypersensitivity, tooth loss, xerostomia, oral precancer, and cancer that are also very popular in Taiwan, and attrition and tooth root fracture. That will be the major topic I will present today. Tooth and crown fractures can be classified into tooth fracture related to dental trauma and the root fractures related to dental trauma, and the crack fracture cusp related to occlusal phosis, and the cracked tooth, split tooth, or vertical root fracture, and 2 other types of root fracture, such as horizontal root fractures in posterior teeth without dental trauma, and addition, the cemental tear, a special type of surface root fracture that are also very popularly noted in the aged population of Taiwan. In tooth fracture related to trauma, tooth fracture is commonly associated with impact trauma and may be involved enamel, dentin, root, or even dental pulp. Traffic accidents are among the common causes. This type of traumatic fractures mainly occurs in the anterior teeth. Dental trauma may also potentially lead to root fractures, such as mainly the horizontal or oblique root fractures. Root fractures implies the fracture of the cementum, dentin, or even the dental pulp. These injuries are relatively infrequent, occurring in less than 3% of dental injuries. Coronal segments may displace to a varying degree, but generally the apical segment of root is not displaced. About 25% of root fractured teeth require endodontic treatment due to pulp necrosis of the coronal tooth segment, but the apical pulpal circulation is usually not disrupted. Thus, the pulp necrosis in the apical segment is extremely rare. For crack and fracture cusp and teeth, crack and fracture cusp and teeth may not be associated with dental trauma, especially in the posterior teeth. These types of crack and fractures are frequently resulted from accumulating perceived or unobserved trauma, resulted from either normal, excessive, lateral, or vertical occlusal forces that repeatedly applied on the teeth without patient's awareness. A crack fracture cusp is defined as a crack between a cusp and the remaining two structures. With time, the crack may propagate and even loss of the tooth structure, and eventually result in fracture cusp, as noted in the right pictures. The early clinical manifestation of cracked teeth and fracture cusp and teeth include sharp pain upon chewing, selective hypersensitivity percussion. The pulp vitality generally can be vital, and the response to cold stimulus may be normal. But with time, the response may resemble a pulpitis condition. The late manifestation, the crack may possibly propagate and result in cusp fractures. If fracture line occurs obliquely coronally to the periodontal ligament, the fracture portion will separate from the tooth. The diagnosis of crack and fracture cusp and teeth depends on the patient's history, such as chewing hard food or hard particles, such as bittersweet chewing is one of kind of food structure. And the bite test can be used to generate a sharp pain, which occurs upon pressure or pressure release. Pulp vitality proven tests can be measured. It is very important to know and examine the crack line and their distribution on teeth and the occlusal surface, without magnification. Such as this is a crack and split tooth. Continued normal excessive masticatory force, bruxism, clenching, occlusal prematurity, extensive intracoronal restoration, patient's dietary habit are the possible etiology and the predisposing factors of crack and fracture cusp and teeth. Certain teeth, such as the mandibular second molars and the maxillary premolars, are more susceptible to developed tooth crack. Sometimes we may look vital root fracture, such as fatigue root fracture, as proposed by Dr. Ye, is used to describe the fracture result from an excessive or repeated or heavy masticatory stress applied to a tooth. The treatment plan of cracked tooth include occlusal reduction of the tooth, can be done to remove the tooth from active occlusion, and the radiographic examination and pulp vitality test should be done. And the endodontic treatment is indicated only if signs and symptoms of pulpal pathosis are observed. Treatment depends on the amount of remaining tooth structures. You may also protect the affected tooth from occlusal force to prevent pain while chewing and the propagation of crack into a full fracture. We may place an orthodontic band or a provisional crown to protect the cracked tooth. A full coverage crown or onlay is also recommended. For crack and split tooth, if the crack is allowed to propagate longitudinally, the tooth will eventually fracture into two fragments, resulting in a split tooth. When the tooth is split through its whole length, extraction is usually the only treatment option. If the removal of the small fragment preserves enough tooth structure that is restorable, retention and restoration of the tooth may be considered. This is a paper published from our research group investigated the cracked teeth, the distribution and survival at 6 months, 1 year, and 2 years after treatment, published in Journal of Formosan Medical Association. We included 77 cracked teeth from 65 patients. The demography, clinical examination, treatment modalities, and record data were collected. And the binomial and multinomial tests were used to value the distribution pattern. These clinical pictures show the presence of various cracked teeth identified in the maxillary molars, many in mesial-distal side, or some teeth in the palatal side, the crack line. And the maxillary premolars, many mesial-distal direction, or only one direction. And the mandibular molars can be first molar or second molar, especially type of crack line may be over the second molar distal marginal ridge. That is also popularly noted in clinically. The results show that most of the patients with cracked teeth were older than 40 years old, occupied 94%, with significant difference, ranging many from 40 to 69 years old. But no marked difference of tooth crack instance in gender was found. The cracked teeth were found mainly in mandibular molars, maxillary premolars, and molars that have specific site preference. No crack in anterior teeth and mandibular premolars were found in this study. Most of them were found in non-endodontically treated teeth for the cracked tooth. Most of the cracked teeth were without abscess sinus tract with no or only passive mobility, with biting pain, and most of crack were in mesial-distal direction. The treatment options can be follow-up, composite filling, root canal treatment, followed by crown fabrication, or provisional crown or stainless steel band placement, then placement of permanent crown, either with or without the root canal treatment. That depends on the pulp status. If the prognosis was hopeless, extraction can be performed. The cracked tooth was categorized as survived if it was presented in the dental arch, asymptomatic and functional. The survival rate was about 87% at 6 months recall, and 76% at 1 year, and 63% at 2-year recall. The survival and the failed cases number and the statistics analysis at the 6 months, 1 year, and 2-year recall were presented in this table. No significant difference was discovered regarding the survival rate and the gender, age, or tooth position in this study. Vital teeth with normal pulp, moderate, or even severe cold sensitivity show higher survival rate at 2-year recall compared to non-vital teeth with significant difference. Cracked teeth without palpation pain, without spontaneous pain, and with no or only passive mobility before treatment show higher survival rate at 6 months, 1 year, and 2-year recall. No significant difference was found between survival rate and biting pain, direction of crack, and the subgingival extension. In summary, the cracked tooth show no significant difference in the distribution of gender and found mostly in patients aged 40 to 69-year-old. Most of the cracked teeth were mandibular molars and maxillary premolar or molars. Common clinical features are percussion pain and biting pain. Most of them are noted in non-endodontic treated tooth. And a higher survival rate was significantly noted in cracked teeth without palpation pain, spontaneous pain, with no or only positive mobility and in vital tooth. The unique and value of our study is provide the survival rate of cracked tooth with different time points. The other popularly noted in aged population is vertical fracture. Vertical fracture is defined as a longitudinal oriented fracture of the root, which is usually directed in the buccal-lingual plane. Mandibular molar and maxillary premolars are the teeth with greatest occurrence. Vertical fracture occurs mainly in those with cross-section narrower mesial-distally and in deep ovoid flattened shape. They occur often in endodontically treated tooth, but occasionally in non-endodontic treated tooth, also named as vital root fracture. That is also sometimes noted in Taiwanese population. Clinical symptoms and signs in vertical fracture. From the literature review of vertical fracture, about 40 to 90% of fractured teeth show narrow, deep periodontal pocket and a radiographic bone loss. About 40 to 70% of teeth show moderate to mild to moderate pain, but no consistent results regarding abscess and the sinus tract. Common radiographic features of vertical fracture include separation of root fragment and the fracture line along root surface and space beside root feeding material or space beside post, a widening of the periodontal ligament, and also the resorption along fracture line, radiolucent harrows, or step-like bony defect or V-shaped diffuse bone loss. Popularly the clinical features of vertical fracture teeth. The method for vertical fracture diagnosis include translumination, magnification, under microscope or light. Clinical examination, periodontal provision depth, usually narrow pockets are present. And you can also remove all restoration to look the fracture line, direct inspection or under the microscope. Or you may also do dye staining by methylene blue to look the crack line. And you may also use radiographic examination or exploratory surgery for confirmation of vertical fracture. Here are some cases collected during our clinical practice. A vertical root fracture was observed and detected during clinical examination of the mesial-buccal root of maxillary left first molar. But most cases that are not directly inspected, some of cases we should do exploratory surgery for confirmation. And other vertical fracture teeth may be directly inspected and diagnosed from radiograph, such as in these two cases. Combined CT radiograph can be useful for diagnosis, such as in these cases. From the periapical radiograph, the vertical fracture cannot be definitely identified, but from combined CT image analysis, you may look the vertical fracture line over the CT image and also the 3D image of the teeth. Sometimes exploratory surgery is indicated to examine the root fracture and further diagnose the presence of vertical root fracture. Because the deep pocket over localized along with the vertical fracture line, like this. And exploratory surgery may also detect most vertical root fracture directly This may save the clinical time for prior endodontic retreatment and appointment for apical surgery. Like in this kind of cases, you may do exploratory surgery to further confirm the presence of vertical root fracture and may make a early decision for the treatment planning of the teeth. How about the etiology of vertical fractures in endodontically treated teeth with vertical fracture? Vertical fractures may be an iatrogenic complication occur during or after root canal treatment or after the insertion of post, retentive screw, and pins. But in non-endodontically treated tooth with vertical fracture, also the name of vital root fracture, sometimes found in Taiwan, aged population or bitquituous, the physical trauma, occlusal prematurity, repeated heavy or stressful chewing habit are the possible contributing factors. The treatment options of vertical fractures include extraction of the affected tooth, or we may do root amputation in some multi-rooted tooth, such as mesial root amputation or mesial buccal root or palatal root amputation. But if the remaining tooth structure and supporting bone are sufficient, root amputation may be the option for the multi-rooted tooth. This is research published in the Journal of Endodontics in 2017 by our study group. The research topic is clinical and radiographic characteristic of vertical fracture in endodontic and non-endodontic treated tooth. A total of 65 teeth with 68 vertical fracture root in 58 patients were collected from 2006 to 2016. And clinical examination and radiograph image were collected. We analyzed and found a total of 25 male and 34 females patients aged from 25 to 90 years old. Most vertical fracture teeth occurred in patients aged from 40 to 79 years old. About 51 patients presented one tooth vertical fracture in the dentition. But there are also several cases have two teeth with vertical fracture in the dentition, and even more vertical root fracture teeth in the same patient, indicating the possible presence of additional offending factors possible present. This is a special case with vertical root fracture in 4 non-endodontic treated tooth. The actual reasons for such many vital root fracture cases is not clearly known. From tables, vertical fractures occur mainly in the mesial root or mandibular molars, and then maxillary premolars and maxillary anterior teeth. For vertical fracture in non-endodontic treated teeth, attrition of the occlusal surface was a common finding, as shown in the clinical pictures. And the common radiograph findings of vertical fracture include periodontal bone loss, apical bone loss, periodontal ligament widening of root canal space, and the separation of root fragment, and the displacement of fracture fragment. For summary, the teeth with vertical fracture show clinical features of deep pocket with prosthesis, prior root canal treatment, periodontal bone loss, and apical bone loss. This study highlighted and illustrated some clinical and radiographic and diagnostic features to facilitate the identification of vertical fracture. The other type of root fracture is horizontal root fracture in posterior teeth without dental trauma. That is seldom mentioned clinically, but recently, we have found many cases and indicated their possible specificity clinically. This also mostly in the aged population. The fractured tooth may probably remain vital and symptomless. After a time period, symptom and signs may become more evident as pulpal and periodontal tissue progressively involved. Pain, localized soft tissue swelling, tooth mobility, periodontal deep pocket, sinus tract abscess formation, sensitivity to percussion or palpation may be presented. The radiolucent line may not be inspected on the radiograph image all the times. That easily to be detected in the premolar, but sometimes in the especially in the maxillary molar, the fracture line cannot be definitely identified clinically from periapical radiograph. Apical bone loss and periodontal bone loss are often noted. Fracture root separate from root structure can be noted, reveal a conclusive diagnosis of root fracture. Diagnosis of posterior horizontal root fractures can be accomplished by clinical and radiographic findings. Multiple shift X-ray can be taken, but combined CT is very useful to confirm the posterior horizontal root fracture. And in certain cases, exploratory surgery can be an option, such as root fracture, such here. Here are some clinical cases of horizontal root fracture in posterior teeth without dental trauma. The horizontal root fracture was detected clinical examination here and here. But sometimes cannot be directly detected by the radiograph, but we can detect some cases under the microscope during root canal treatment. You may use microscope detection, or you may use endometer detection, or root canal breathing also can be used to confirmation or suspect the possible horizontal root fracture within the root canal. And exploratory surgery can further confirm the presence of posterior horizontal root fracture. Especially this kind of root fracture is popularly found in the palatal root of maxillary molars. That is very interesting. This is combined CT image analysis that is very useful to detect the horizontal root fracture on the maxillary molar that is not so always can be detected, while this horizontal line should be suspected. This is the other case we can also use to suspect the fracture line over here. But this looks also like furcation involvement or periodontitis, not definitely the horizontal root fracture. But during endodontic treatment, we may look at the change within the root canal. And we may also use combined CT analysis to confirm the presence of posterior horizontal root fracture. I say especially in the palatal root is more popularly affected root. This is also a case in lower premolar with horizontal root fracture. We may look at the displacement, not homogeneity of the root surface, and the combined CT image to detect the horizontal root fracture. Exploratory surgery can be done in some cases for confirmation, such in this case, this palatal root fracture. This is also distal buccal root fracture, or horizontal root fracture. This is a study of horizontal root fracture published in International Endodontic Journal in 2018. A total of 24 patients. Before this paper published, there are only about 8 cases of case series study about posterior horizontal root fracture. We collected 25 patients and 31 horizontal root fracture cases in 28 posterior teeth were collected. And the result of this study shows that the number of male was similar to female. Patients were aged from 50 to 70 years old. Most of the horizontal root fracture cases were found in maxillary molars papilla affected tooth, and with periodontal province depth greater than 5 millimeters. But this should be special mention about that this kind of case always have wide periodontal pocket. That is very different from the narrow tip pocket found in vertical root fractures. Okay. And without crown and bridge restoration, with from full mouth chronic periodontitis, and with relative intact dentition, most of this case is found in the non-endodontic treated tooth. That is also different from the vertical teeth with vertical root fracture. Fractured teeth usually presented with periodontal and apical bone loss and found in non-endodontic treated tooth. About 79% of teeth are in non-endodontic treat, and without porcelain core in the root canal. That is very interesting of kind of root fracture. So horizontal root fracture in posterior teeth without dental trauma is a diagnosed challenge and even misdiagnosed, especially in upper molar teeth. A thorough clinical examination, radiographic analysis, recognition of clinical characteristics are helpful in early diagnosis and the treatment of horizontal root fracture. And the additional type of root fracture is cemented tear. That is also very popularly noted in aged population of Taiwan. That not so rare as reported previously. We have many cases about clinical pictures of cemented tears. This will show that cemented tear we published in Journal of Endodontics in 2011 with Professor Dr. Lin and Dr. Chen. This is kind of spatial kind of surface root fracture at cemental or cemental dental junction in aged population. That earlier studies always reported in the Journal of Periodontal Disease, but now it's also in the endodontic lesion. That should be very carefully. And also, we can find the apical environment. So we should take care of this problem. Okay, so this is the clinical cemented tear that we should special care for this point in the future. Due to time limitation, we may talking about this is a summary of before. And we may have some suggestions. Taiwan has become aged and super aged population, so we should take care of systemic disease of the patients. We may provide oral hygiene instruction, diet control, fluoride application to prevent the disease, and provide a variety of periodontal treatment to control caries of periodontitis. And we should take care of missing tooth that may affect the function of people of Taiwan. My suggestion is provide oral function evaluation, oral microbiota, saliva evaluation, or carotid artery calcification, dysphagia, and so on. And especially the radiographic or oral conditions related to various systemic disease. We have some cases, such as this case, 48 patients have carotid artery calcification that is have a stroke 2 years after dental implantation done by me. So there are many aortic calcification. This kind of cases in the aged population may have can be a predict of streaks of stroke in the future. Okay, we may also provide many support for the aged population in Taiwan. Okay, thank you for the time. So thank you for Wan Shen Liao and other factors for help for these studies. Thank you very much.
Thank you. Professor Zheng is an endodontist. So that's the reason why he has such a good experience in root fracture. Thank you, Professor Zheng. Let's give him a big round of applause. Thank you. Okay. Because we have to catch up our schedule. So let's move to the next speaker. And at the end of this session, there will be a panel discussion. If you have any questions, we can raise the question afterwards. So the second speaker, it is my great honor to invite Professor Lakshman Samaranayake. Professor Sam is a professor emeritus, graduate school, faculty of dentistry, University of Hong Kong, and he is currently the editor-in-chief of International Dental Journal, which is the official scientific journal of FDI. So, ladies and gentlemen, let's give our big hands to Professor Sam, please.
Here it's here. Good afternoon, everybody. And first of all, I would like to thank Professor Alan Su for the kind invitation for this meeting. And this is my maybe 5th or 6th visit to Taiwan. And it's a great place to be. Also for the Ministry of Health and Welfare. So we are talking about the paradigm shift to face the challenge of super age society of Taiwan. And what we are thinking about is this cartoon explains very well what the paradigm shift is, you know. We think in a totally different manner. And in that context, we have to think about treating the two major diseases in dentistry, as my colleague earlier explained, periodontal disease and caries. And for last more than 100 years, we have been studying this, you know, but still we cannot control this for one reason or another. I don't have time to go into the reasons. So how about targeted therapy for these oral diseases, particularly for caries and periodontal disease? So that's my presentation title, and let's talk about this. And so this is how I'm going to talk about it. I talk about what targeted therapy is. And I don't know whether you have heard the new term for the oral microbiome and oral microbiome as well as the whole oral cavity. It's called the oralome. And I'm going to give you some new data. And the functionality I will be discussing later. Thirdly, why and what is targeted therapy? And finally, I will show you 5 different approaches to targeted therapy. And so let's get on with it. So if you're talking about the oralome, the new data, we have to go back to basics. And some of you may have seen my textbook, but I am doing the new edition. There's so much new data coming along. And so possibly you will learn a little bit new data here. Now, if you go to the oral microbiome, as it were, a few years ago, Nature published this seminal article. It's called The Fellow Travelers, the organisms which are traveling with our body all the time, whether we like it or not, right? So, and they actually produced this article, which is shown here, The Structure, Function, and Diversity of the Healthy Human Microbiome. It was by the Human Microbiome Consortium, as you can see here. And this together, they used next generation sequencing data, which is a new technology, as you all know, to assess the microbiome and the microbiota. Now, our old cultural techniques are now gone out of the window. we are all using NGS and the next generation sequencing and the new generation sequencing. And with this data, they found that each human being has a fingerprint. I am different from somebody else, and each one has a specific targeted, a specific fingerprint of organisms. And even within the same person, you can see the clustering of similar organisms, gastrointestinal tract, and look at this oral cavity. These are similarity indices, and you can see in the oral cavity that these organisms are totally different. So we have got to find, and nobody knows the reasons for this. There are so many possible reasons, but again, I don't have time to go into this. And again, the human oral cavity and the human microbiome is actually much, much smaller than the gut, much more smaller than the microbiome, including the gut and the oral cavity. You can see the disproportionality of the microbiome versus human genome, as it were. So as you know, the humans, we have a genetic constitution, and we are eukaryotes, and the microbes are called prokaryotes. I'll come back to this in a minute. And now this is also called the metagenome, and the metagenome has a huge effect on our health. And this is, as we'll see later, is called the oral systemic axis and gut systemic axis, and so on and so forth. And you can see here, I'm going to have time to go into details, so many different conditions associated with the microbiome and the microbiota, also in the oral cavity we'll see later on. And this is the oral systemic axis, which we are talking about. Right, okay, thank you very much. Oral systemic axis we are talking about, where we have the 4 key diseases, such as atherosclerosis, low inflammation-induced pregnancy complications, then various other diseases, such as hospital-associated pneumonias and diabetes, are all associated with oral diseases. So there's a huge link between oral health and systemic health, particularly with the oral microbiota. And also we have found that through various studies that during diseases such as cancer, the microbiota in the oral cavity changes. And again, this is shown here. You can see here at the top in the health, you have the disease conditions, cancer, you get these kinds of organisms coming up. Again, it's a very, very complex data, but this shows you that the microbiota has a great effect on various diseases. So from the human microbiome, let's get on to more focus onto the oral microbiome. So some definitions, the totality of all the organisms in the human oral cavity and their ecosystem is called the oral microbiome, right? And what is oral microbiota? And these things are not synonymous. Microbiome and microbiota are 2 different things. And the totality of bacteria, archaea, fungi, viruses, phages, and protozoa in the human oral cavity is the microbiota. Now, I'm going to explain this in the next few slides. Now, if you look at the oral microbiome, by far the largest component of the oral microbiome is the oral bacterium, right? And then there is the second level we call the oral archaeome. And this is something new, because now I don't have time to go to details, but archaeobacteria are the bacteria which you see in hot water springs and various other so-called highly stressed environments. And for example, there is a organism called Methanobacterium oralis, which is thought to be associated with periodontal disease, and that's a archaeobacteria. So it's called archaeome. So essentially, although we said at the very beginning that the bacteria were so we had the prokaryotes and eukaryotes, right? Eukaryotes and prokaryotes. Now the prokaryotes are divided into bacteria and archaea, and this is now called the oral archaeome. This is something new which you may not know, perhaps. Then this is the oral archaeome. These are these new kind of bacteria which are found in the oral cavity. They are very difficult to distinguish from the normal bacteria, but they have been found through new technology. Then you have the microbiome. Microbiome is fungi, okay, in the oral cavity. And earlier we thought it was only Candida, but now we know there are other species, lots of other species, such as Malassezia species and so on, colonizing the oral cavity. Again, this figure shows you these organisms. Okay, so that is the oral microbiome. Let's get on to the other one, which is the oral virome. There is a viral component as well. And this, of course, you know all about this, the herpetic group of viruses, and you can see the various viruses here again in this super diagram. And so again, there is a virome as well associated with the oral cavity. And last but not least, there is a thing called oral phageum. So what is phages? Phages are small viruses which actually infect bacteria. You can see here, phages can infect bacteria. And what are their properties? They drive bacterial diversification and helps in biofilm formation and so on and so forth. So I'm quickly going through this lot here because I need to finish this. And in 15 minutes, so this is what it is. And then there is protozoa as well. And this is not included in this. This is called the protozoum as well. So it's a very, very complex picture you see in the oral microbiome. Now, so we have done our new data on this. The functionality, I think most of you know this, so I will very, very quickly go through this. So that is, in the oral cavity, microbiota exist either as suspended planktonic phase or the biofilm phase. So the biofilm phase organisms are the most common, and they are the predominant constituents of the oral microbiome and the oral biofilms, right? And they are responsible for 65% of all infections in general are related to biofilms. So similarly, in the oral cavity, caries and periodontal disease, the two key diseases are related to these biofilms, and possibly things like cancer as well. So very quickly, I go through the biofilm formation on a surface. And here we have a initial colonizer coming through onto the attached to either mucosal surface or enamel surface. They attach, then produce secondary colonizers and co-adhesion, and then some detachment, and finally they become big communities and form mature biofilms. And they are like, big cities like Taiwan or Hong Kong. They have their own way of transportation, water channels, metabolites, output, and nutrition input, and so on and so forth. And also, when the colony, the biofilm comes to a certain size, they have chemical inducers. They are called autoinducers or quorum-sensing molecules, which ask the organisms to move out of the biofilm, and then they are kicked out of the biofilm as it were. And this is very important because I'll come back to this when I'm talking about targeted therapy, and people are talking about using autoinducers and these other type of quorum-sensing molecules for targeted therapy. Okay, so I'm going to quickly go through this. So and these are some of the pictures of the specificity of this. So now we come to a major theoretical construct here, where I'm sure all of you know about the beneficial biofilms and the pathogenic biofilms, right? And these beneficial biofilms are the biofilms which we have on a healthy mouth, which is symbiotic state, and the pathogenic biofilms go to, that means that the biofilms are in a dysbiotic state. Right, so health to disease. How does this happen? Now, initially you get the good bacteria, which are in green, and a little bit of the nasty bacteria, which are in red, right? So for various reasons, major ecological pressures and temperature and diet, pH, and so on, this symbiosis becomes dysbiosis, and then you get the supervening of various diseases like caries and periodontal disease and various other diseases. And these are, the dysbiotic bacteria essentially these are the so-called periodontal pathogens. You see at the top here, I'm sure most of you know about this, P. gingivalis, T. fossitesis, and denticola, and so on and so forth, right? So that is a little bit about the functionality of the oralome and the oral microbiome. And now, why do we, for the next 10 minutes, we can talk about the targeted therapy. Why do you want targeted therapy? Now, all this while, we have been using antibiotics and various other chemicals and, disinfectants to kill bacteria, right? And in the oral cavity. And so-called, what we're doing is carpet bombing all the organisms, common cells, the good guys, as well as the pathogens. So once you do that, you need to have a new generation of organisms growing, and I don't know whether this is, as far as we know, this is not very good. So the theory is that targeting a specific pathogen will tip the balance in favor of eubiosis from dysbiosis. Eubiosis means going back to a good biotic situation. So for these purposes, there are 5 different approaches people have been talking. So I have got 3 slides of each of these approaches. And these are essentially antimicrobial peptides, prebiotics, probiotics, nano drug delivery systems, and matrix disruptors. So I will take you through these 5 different targeted therapies within the next 10 minutes or so. So antimicrobial peptides are, as opposed to antibiotics, targets bacterial groups, and they are membrane active molecules, as you can see here. And these are some examples: niacin, bactericin, like antimicrobial peptides produced by lactobacillus lactase, and they're active against both gram-positive and gram-negatives. Then these are some of the properties of these niacins, but I don't have time to go through all this. So niacin is an antimicrobial peptide. The others are, you see here, peptoids, beta peptides, and so on. But that has challenges. It's resistant development, and as they could be allergens and host sensitizers. Then we can have nano-sized drug delivery system. I'm sure all of you have heard about nano drug delivery systems. Comes in all sorts of shapes and sizes. And these are small nanoparticles: silver, copper, titanium, zinc oxide, and so on and so forth. So polymeric nano-DDS capable of releasing quorum-sensing chemical. I was talking about the quorum-sensing molecules which disrupts the biofilm exopolysaccharides, and this is what we are talking about here. So it can disrupt only the aciduric dysbiotic biofilm, and perhaps can be used in potential in caries reduction. So, for example, S. mutans biofilm reduction has been shown in 4-fold more effectively than the free drugs in vitro. So reduces the number and severity of caries lesions, and so on and so forth. So nanodrug delivery systems are the second system which I was which you saw in that diagram earlier. So this is what it is. The next one is the prebiotics. Again, all of you have heard about probiotics, and some of you may not have heard about prebiotics. I call prebiotics as lunch for bacteria. So that is, you are giving good, this is, as you can see, natural or synthetic food ingredients or supplements that modulate the microbiome to the benefit of the host. So this has been used, prebiotics has been used in managing microbiome, but recently applied to the oral microbiome as well. And some of the common prebiotics are here: nitrate, arginine, and mannosamines. So this could be used to support the good bacteria and target the good bacteria and eliminate the nasty bacteria. And some of the 3 prebiotics which are commonly used are here. The arginine, shown to prevent caries by buffering the acids produced by dysbiosis. Nitrates, and again, both caries and periodontitis increase the ammonia production and increasing pH. Then mannosamine selectively triggers the growth of commensal oral bacteria, again growing the good bacteria rather than killing everybody as it is in the normal situation with antibiotics and disinfectants and so on. Then the 5th one is the probiotics. Of course, we have heard about probiotics. This is the definition: the live microbes which, when administered in adequate amounts, confer a health benefit for the host. So we have heard about lactobacilli and streptococci. So we take lactobacilli in yogurt and all these, and it's all very good. Lactobacillus reuteri is particularly good, and they have activity against the nasty bacteria like P. gingivalis, P. intermedia, and nucleatum, which are the periodontal pathogens which you saw at the top of that pyramid earlier. Okay, so the probiotics are good. So there is another kind called the postbiotics. I don't have time to go into that. If you have enough time left, we can later discuss that what postbiotics are. So you have prebiotics, probiotics, and postbiotics. This is something which you will come across in the literature later on. This is relatively new. Anyway, postbiotic therapy is becoming more and more common in gut disorders. So preclinical and clinical studies indicate that probiotics reduce gingivitis, plaque, alveolar bone loss, and modulate pro-inflammatory effects. For example, these are some examples. Chewing with Lactobacillus reuteri led to reduction in gingivitis in patients with moderate to severe gingivitis. Bacillus subtilis reduced bone loss and attachment loss in rats with ligature-induced periodontitis. Okay, so I got 2 or 3 minutes more and finish. And there is another organism people are talking about. It's called Streptococcus dentisanis. And that actually is a very good probiotic, which if you can introduce into caries cavities, it replaces the strep mutans. And it is a streptococcus which is very, very innocuous. And there are some studies which indicates that it's as an oral probiotic. It's published in these guys by Lopez and Lopez in Frontiers. And you may hear about this Streptococcus dentisanis and another probiotic which can be used for caries. Now, what about the microbial restoration using transplants? Now, this is something concept which has been taken from the medical practice. So, you know, you have fecal transplants, as you can see here. Healthy donor gives the fecal sample, and it's taken to given to patients with Clostridium difficile infection, and then restoration of microbiota. This theory has been applied in dentistry as well, where they are saying that if you get a healthy donor and healthy sample of saliva and give it to a patient with, let's say, Candida infection, right, without giving nystatin and all these other antifungal agents, then you can get restoration patient after transplantation. So eubiosis, dysbiosis, and eubiosis. So this is something which is, again, which people have been talking about targeted therapies. So the drawbacks of probiotics are large number of probiotic cells needs for prolonged periods in target sites. It's very difficult to transport them in viable form, as you can see here. And you may be able to use the nano-sized drug delivery systems for this condition. And the last one I am going to talk about is the extracellular polymeric matrix destruction. So you saw that in the biofilm is retained through the extracellular polymeric substance called the EPS, and this is extracellular polysaccharide. And if you can disrupt this biofilm in caries or periodontitis, then there may be a situation where it can be targeting this biofilm area and then becoming a good therapy. So EPS disruptors have been talked about. Then two main strategies are disrupting synthesis, extracellular polysaccharide synthesis, disruption, and secreting and targeting its composition and structure. So there are a number of chemicals which has been used for this purpose, and then also a lot of enzymes, number of enzymes can be used to degrade that extracellular polysaccharide, dextranase, mutanase, and dispersin, and so on and so forth. So that actually is a very, very quick roundup of the targeted therapies which people have been talking about in dentistry. And so top 5 take-home messages here is oralome is far more complex than we thought. As you see those dendrograms, we draw 6 or 7 different types of organisms living in the oral cavity. And multi-drug resistant antibiotics increase the urgency for development of targeted therapy. You know, that's another area which I didn't get into. And there's a multitude of approaches for targeted disruption of pathogens to convert dysbiosis to eubiosis. So we have so many different approaches, but all are in experimental stages, but you know, we need to try in the future. So targeted disruption of microbes can be used to replace antibiotics in the future, that is for sure. Two major diseases of humans, caries and periodontal diseases, are likely to be amenable to targeted therapy. So once again, thank you very much, ladies and gentlemen, for listening to me. And again, I wish to thank Prof. Alan Suru for the kind invitation. And we can discuss anything later on. Thank you so much.
Thank you. Thank you, Professor Sam. I think with Professor Sam's presentation, we can predict that oral disease therapy can be more promising with this microbiota targeted therapeutics. Okay. So let's move to the next speaker. It is a great honor and a privilege for me to introduce you the next speaker, Professor Hiroshi Egusa. And Professor Egusa is a professor of a graduate school of dentistry, Tohoku University, Japan. And he's the director of Liaison Center for Innovative Dentistry and the director for Center for Advanced Stem Cell and the Regenerative Research, and as well as the General Vice Director, Tohoku University Hospital. And again, today we have 2 editor-in-chief. Okay, and Professor Egusa is editor-in-chief of Journal of Prosthodontic Research. Professor Egusa, please.
Okay, thank you very much, Professor Allen, for your kind introduction. Good afternoon, everyone. I'm Hiroshi Egusa from Tohoku University, Japan. First of all, I'd like to express my great appreciation to distinguished Professor Allen Min-Leun Soo and the forum organizing committee members for giving me this wonderful opportunity. And I'm a clinician, prosthodontist, and also scientist studying on the regenerative medicine. And today I'd like to talk about tissue engineering toward a paradigm shift in oral health and the point of view of the prosthodontist. Okay. You know, I don't know whether this kind of tooth extraction method is still accepted or not. But whatever the extraction method is, after the tooth loss, the jawbone resorption is unavoidably occurred by the activated osteoclasts. And it sometimes leads to severe bone loss, which makes it difficult to perform appropriate dental implant because we need bone to place dental implant. And also the flattened alveolar ridge like this causes unstable dentures. So that we are waiting for the new technologies to regenerate missing oral tissues, such as periodontal tissues and jawbones, and ultimately the lost tooth itself. In a prosthodontic treatment, we often meet a case like this, that she has a very severe bone resorption. And when we meet this kind of patient, conventional prosthodontic approach use unstable denture base like this. It's not looks beautiful. Or using bridge, but with ugly pontic, long ugly pontic, so that this kind of processes are not so comfortable for patients. So now, tissue engineering, the delivery of stem cells and biofactors and scaffold has become the new frontier in dentistry to achieve regenerative therapy to get a better functional and aesthetic treatment outcomes. However, in the case of the large bone defect like this, application only the scaffolds and bioactive factor are not sufficient for the patient stem cells migrate into this space. In that case, we might need a cell-based regenerative approach. So today's my topic will be focused on stem cells. Okay, so what kind of stem cells are useful to make oral tissues? Maybe one of the good candidates are tissue stem cells, like mesenchymal stem cells, MSCs. But you know, the differentiation capacity of the mesenchymal stem cells are limited mainly to the mesenchymal lineages. And also, proliferation ability of MSCs are also limited. Then, maybe the next candidate would be the pluripotent stem cells, embryonic stem cells, ES cells. However, ES cells always involves ethical issues because we have to destroy the embryo to get the cells. And also, possible immunorejection following the transplantation of the non-autologous ES cells is another problem of ES cells. So in 2006, Dr. Shinya Yamanaka in Kyoto University discovered epoch-making stem cells, namely iPS cells, which can be generated from somatic cells by reprogramming of cell memory by genetic manipulations. And iPS cells are considered to be identical to the ES cells so that they can differentiate into any type of cells and tissues theoretically. And iPS cells can be generated from any type of cells, somatic cells, as long as the cells can proliferate. So I'm a dentist, so when I listened to the report from Dr. Yamanaka, I thought, okay, for dentists, which part of the tissue would be good for as a cell source of the iPS cells? So we selected gingiva. To test this hypothesis, we collected the patient gingiva and we introduced the Yamanaka factors, and so we got this kind of iPS cells. And these iPS cells can differentiate into many types of cells and tissues from the main three germ layers, from ectodome, endodome, and mesodome. And some clumps of iPS cells spontaneously started to beating like this. So that means gingiva was switched to beating heart cells. And here, the very important, it should be noted, the important characteristics of the iPS cell is spontaneously to self-organize to make the 3D structure like this. This is very important characteristics of the iPS cells. So one of the keywords in my talk today is organoid. An organoid is a simplified version of a mini organ in vitro, and which is a production in vitro in 3D by self-organization of stem cells. And it is recognized as one of the biggest scientific advancements in this decade because it has great potential to study disease and treatments, and which of course includes the dental fields targeting tooth and jawbone and salivary gland. Okay, so we started with fabrication of 3D cell constructs for bone organoid formation. We use this temperature-responsive NIPAM gel container as an iPS cell culture. We added the iPS cells to each well, so that a few days after that, the cells are automatically gathering and make a sphere. And we can just change the temperature, then the gel expanded. Then we can collect the cell sphere easily. So we can obtain the size and shape control iPS cell constructs like this. And also, when we cultured these spheres in the osteogenic induction medium, they show robust calcification like this. And interestingly, this cell construct shows two-layer structures, the white-colored core surrounded by the translucent layer. And the white-colored core in the inner region contains a very highly calcified cell mass, and outer region shows the bone-like structure like this. It's surrounded by the aligned osteoblasts. So it's not a simple aggregation of the osteoblast. It's spontaneously self-organized to make more sophisticated tissue like bone. So it means the specific culture environment produced bone organoid. Indeed, we found that the specific culture, microculture size promoted the iPS cell differentiation into 3D differentiation into the bone organoid. And these produced bone organoid enhance bone regeneration in vivo in the animal models. So these findings suggested that the in vitro manipulation of iPS cells can be manipulated by environmental factors like a space or mechanical stimuli. So we established a bioreactor like this to raise the intermittent committant force on iPS cells. And this type of compressive force enhance the proliferation of the iPS cells and suppress the apoptosis of iPS cells. And finally, they pushed the osteogenesis capacity in vitro. And we also found that the simple shaking culture like this enhances chondrogenic differentiation in 3D structure from the induced iPS cells. So we expect that this finding can give rise to an efficient protocol in organoid fabrication by mimicking the physiological complexity. It doesn't work. Excuse me. Oh, maybe the battery out? I don't know. Okay, could you send that slide? Okay, so we made some types of bioreactors to, add some types of mechanical stress to induce bone or cartilage. And yeah. Okay, restart the computer, so it might take time. Okay. All right. So, what shall I talk? Shall we have a discussion before the panel?
So can I have a question?
Yes, please.
So in the presentation, you used the IPS cell for the reconstruction. So do you think the IPS cell is really effective in the dental practice?
Yeah, that's what I'm going to talk about. Yeah, of course we have many hurdles we have to overcome. Yeah, so that's kind of the big issue. So let me skip these things. All right, so I show the effectiveness of the bioreactor mechanical stimuli. Okay, then also the combination use of the microspace culture and the mechanical stress produce the hybrid bone and cartilage organoid like this. So this black part which shows the bone, and the purple part is represent the cartilage part, and this fine. And also we found that we established a protocol to fabricate rapid and efficient generation of cartilage organoid in vitro, which regenerate knee joint cartilage. And interesting, we also found that the mature cartilage organoid like this also regenerate, not only regenerate the cartilage, but also regenerate bone through the endochondral bone regeneration. So based on these findings, so here is our strategy that we can get the information about the size and size of the patient's bone loss, and we can take it out to the in vitro. Then using iPS cells, we can make a 3D bone and cartilage organoids by bioengineering technologies. Then we expect that the transplantation of this organoid have a great clinical potential, I hope so, to enhance the bone regeneration to get a better implant treatment. But yeah, as Jack told me, there's a big issue. You know, from the standpoint of the cost, iPS cell therapy is realistic in dentistry or not. So treatment value is defined as the quality divided by cost. So cost is very important, even if we have a very good, effective technology. You know, iPS cells are already used to the human clinic 8 years ago, and it performed very well on the patients suffering from eye disease. But it doesn't show in this report, but I heard from the company, they estimated how much does it take for one patient. They said $500,000 US or more per patient if done one by one. So if the medical field, the life-threatening disease, maybe which person may pay for it, but how about the dental implant? It's not a life-threatening disease. So we really need to find another way to use iPS cells to clinic. So we started to have a new project, biomimetic bone graft substitute using iPS-derived bone organoids. So iPS cells are pluripotent stem cells, so they have the unlimited proliferation capacity so that we can obtain the mass culture as an organoid source. On the other hand, iPS cells has self-organizing capacity to produce bone organoid, which contains bone components like calcium phosphate and bone extracellular matrix and growth factors. So if we use these organoids as living materials, it brings high cost and tumor risk. So that I thought, why don't we just kill by freeze drying, inactivate these living cells, then just use these bone components as a bone graft substitute. This is the project. Indeed, the freeze-dried bone graft substitute, it doesn't contain any living material, but it shows superior bone regenerative capacity compared to the commercially available products. So this may indicate how to make the stem cell therapy more available, reducing cost, sustaining the quality. So sum up here so far, that this is our strategy for iPS cell-based bone regeneration. So in the large defect, we can use the living iPS cells organoids because living cells has more powerful for the bone regeneration. So this is kind of very difficult treatment, so that the university hospital should do as an advanced medical treatment as a limited patient. But on the other hand, there are lots of patients are suffering from this kind of partial bone defects in the implant treatment or the periodontal disease. In that case, we can use the inactivated bone organoids as bone graft substitute, because that's safer, lower cost, or simple way compared to using the living organoid. So this, I hope, should be used in a private clinic as a general dental treatment, and this technology is now ongoing. And the thing what I talked so far is recognized as one of the innovations in Japan, and they recognize as one of the innovation in Japan, Japanese government, and they kindly made promotional videos for us. So if you're interested, please go to the YouTube. There is a Japanese version and also English version. And I think I should mention about the tooth regeneration, because this is an ultimate goal and the future dream in dental fields. So cutting technology now enable us to make this kind of bioengineering tooth unit, which contains not only the tooth, but also contains the periodontal tissue surrounded by the alveolar bone, which can regenerate the bone and the tooth at the same time at the transplanted site in the animal model. So far, this cutting-edge technology uses mouse embryo cells or dog tooth germ cells as a cell source. So a big hurdle to apply this technology to the clinical application is finding the good cell source from the adult tissue. So iPS cells can theoretically differentiate into any type of cells, including maybe tooth epithelials and the mesenchymal cells, so that iPS cell is one of the candidates for the tooth regeneration. So now we made a protocol, stepwise protocol, to guide the iPS cells to differentiate into ameloblast, so we can get epithelial cells from iPS cells from gingiva. So this part is done. And how about the mesenchymal stem cells? So mesenchymal stem cells, I think we are not necessarily use iPS cells, because we can get MSC, mesenchymal stem cells, from adult tissue. But single cells, it's difficult to combine the epithelial cells and mesenchymal cells. So I made a protocol to produce a 3D MSC construct, spheroids, with neural crest phenotype, which shows more primitive mesenchymal stem cell phenotype that facilitates to make the epithelial cells and mesenchymal cell interaction. So far, we can get this kind of tooth bud using a mixture of combined of these technologies. So far, our strategy is that the emerging approaches for regenerative prosthodontics should be expected, particularly for the bone augmentation in challenging bone defects. And the coming cutting-edge technology like iPS cells and organoids enable us to make more effective stem cell-based therapies as a future challenge. So this is one of the sum up. And at the last part of my presentation, you know, this session theme is a paradigm shift to face the challenge of Super 8 society in Taiwan. And also Japan is facing the Super 8 society, so we share the same problem. So last part, I'd like to mention about my thought, how technology in regenerative medicine contribute paradigm shift in oral health. You know, we are facing Super 8 society where we may obtain so-called the 100-year life. So English historian Peter Laslett divided the life course into 4 categories. And first age, from birth to adult, is defined as a dependence period by receiving education in schools. And second age is period of productivity with active working life. Now I'm in the middle of this age, working hard every day. And the third age, that is after retirement, that is the most important life stage, as Peter Laslett says, because they have freedom for time and environment. They finish the task of the working, and they finish the child care. So, and they have saving money. So they have freedom of achieving personal needs and passions. And Laslett called this life stage as crown of life. And the fourth age is the last part of old age before death with independency. And, you know, oral health promotion by controlling the caries or periodontal disease or maintaining the oral function by preventing oral frailty is recognized to extend this period health life expectancy, resulted in the prolonged crown of life. So I'm very looking forward to my retirement after retirement because, yeah, the crown of life, this age, is the longest life stage compared to other stages if I have the 100th-year life. So regenerative dental medicine may enrich this longer crown of life because patients are satisfied with eating, more satisfied with eating, thanks to the regenerated periodontal tissues or tooth or dental implant treatment. However, it's not so simple. It's not so simple because there is a big variability in patient response to disease prevention or treatments. For example, there is a wide variation in jawbone, long life jawbone resorption among patients after tooth loss. All prosthodontists suffer from this. We cannot predict this kind of severe atrophy before tooth extraction. So there are many factors involved in this severe bone resorption. But recent finding highlighted the influence of genetic predisposition on the severe bone resorption. In addition to the jawbone resorption, there are many interactable diseases in dentistry like this, but we haven't yet know the molecular and genetics basis for these diseases, so we cannot predict when it happens or who get this kind of disease. And let's get back to the iPS cells and the organoid. iPS cells can be generated from each patient so that the generated iPS cells are patient-specific iPS cells. And if we can differentiate into these patient-specific iPS cells to disease part of tissues using the organoid technologies, what I showed, we can get the patient-specific model of oral diseases, which can be used as a tool as a tailor-made diagnostics for investigating new therapeutic approaches and patient-specific drug discovery on the molecular and genetics basis. So, which may bring personalized and or precision dental medicine. So I think it is very important direction in the 100-year life. The result of this kind of cutting-edge IPS cells and organoid technologies may contribute regenerative dental medicine, but at the same time, it also useful as a tool to finding, understanding patients' predisposition on the molecular and genetics basis. So, at last, I hope technologies in regenerative dental medicine may enrich the crown of life in the 100-year life in super age society. So that brings me to the end of my presentation. Okay, thank you very much for your attention. And I'd like to acknowledge my collaborators for my today's presentation. Thank you very much for your kind attention. Thank you.
Thank you. Thank you, Professor Egusa, for enrich our crown of life. Okay. And so now we are moving to the panel discussion session. Okay. So,
Okay, thanks to moderator Shi and all the speakers. 我们再次给所有的讲者一个热情的掌声好吗？ Once again, big applause to the moderator Shi and all the speakers. And it is time for panel discussion. If you have any questions, please raise your hand later and wait for your turn. And please press the button next to the microphone to use it. When the red light is on, it means you can start talking. For online guests, please scan the QR code on the screen to send your questions online. 好的，那接下来呢，我们就是综合讨论的时间哦。如果您有任何问题的话呢，在您的椅子旁边都有麦克风，请您按下就是我们的按钮。当红灯亮的时候，就表示您可以提问喽。那另外呢，我们在线上的贵宾，如果您有任何问题想要提问的话，也可以呢扫描一下荧幕上面的 QR code 哦，然后呢，您的问题呢就会送到我们这边，所以请您可以扫描荧幕上的 QR code 来提问哦。好，那接下来呢就是我们综合讨论时间 ，Ladies and gentlemen, it's time for panel discussion. Once again, let's welcome moderator Shi and our panelists, our speakers. A big round of applause. 好，掌声欢迎。
Okay, any question from the audience? Please, just raise. Oh, okay, yes, please. President Zhang.
Sorry, just to come back to my last question for Professor Egusa. So, because you mentioned about the iPS cell maybe can use in some serious cases in the hospital, but how can you tell the mesenchymal stem cell, even the stem cells we got from the PDL or got from the bone marrow, is more effective or not than the iPS cell? And is cost effective or not cost effective?
Yeah, thank you very much for your very important question. So actually, we don't know yet which is more effective between iPS cells and mesenchymal stem cells. But you know, one of the very superior part to use mesenchymal stem cell is they have the immunomodulatory property. But iPS cells, maybe it doesn't have like a mesenchymal stem cells, but they differentiate more real bone compared to the mesenchymal stem cells. So we don't know which is superior in the clinical cases. So next step you'd like to test. Cost-wise, mesenchymal stem cells are already established, so that the cost is not so high compared to the iPS cells. But you know, the iPS technologies now is very quickly developing in Japan, so that maybe cost is maybe becoming similar to the mesenchymal stem cell culture, so that cost-wise, maybe it's going to be similar, but the important point is which is effective. Yeah, thank you very much.
Thank you. Good. Oh, Dr. Lin.
All right. I have a question for Professor Sam. Thank you so much for your talk. So I have a question about drug delivery. So we know that the oral cavity is a very complex environment, like the saliva is washing away, constantly washing away things. So what is your thoughts on how do we make those therapeutics stay longer in the oral cavity in terms of the retention of the therapeutics? Is there any good ways to make them stay on the tooth surface longer? Otherwise, it will just be swallowed by the patients and it goes into the GI tract. Yeah, thank you.
Thank you very much for the question. Yeah, it's a very good question, actually. A number of workers have investigated this aspect. What they are, what they are thinking is this, let's say, nanoparticles, and putting the nanoparticles into a gel-like system, and so that it can be applied onto, let's say, caries, or if it's a mucosal lesion, onto the mucosa, so that it can be a slow-release vehicle. I mean, this is one thing which has been tried out. Actually, this was tried out 20 years ago, but before the nanoparticles came out. So now they are what you call reinventing the technology and trying to deliver that. That's, yeah, it's one of the biggest problems we have in the oral cavity is this very complex environment and very dynamic environment. So whatever you want to deliver, even the probiotics, I was talking about Streptococcus dentisanis, that organism is supposed to be very good for caries, and they are saying you can apply it onto the caries surface and it will displace the strep mutans and cause remineralization. But then how are we ensuring that it's going to retain on the oral cavity unless you put it with some kind of a cement or something like that, which allows it to release it? Yeah, very good question. Thank you very much.
Okay, thank you. I think we can have one more question. Any? Okay. Yeah. Oh, yeah. Please.
I have one question for my friend and student. Yeah. And Prof. So you showed this like the alveolar bone, some of them depending on the composition of genetic composition, very thick or very thin, right? So what do you think, if you can retain by some means with treating periodontal disease and caries and retaining all 32 teeth, that problem will not come there, at least some of the teeth, right? If you grow into the old age, my question is, if you grow into old age with, let's say, 32 teeth or 30 teeth, most of the teeth, this alveolar bone loss will not occur, right?
Yeah, but what I presented is edentulous, edentulous patients. I don't think if the patient has 28 teeth, the alveolar bone loss is more influenced by the periodontal disease, not the genetical part, but of course the genetical part plays some. Yeah, after the tooth loss, only the bone and no bacterial factors, but some patients aggressively produce the germ resorption. That's what I wanted to highlight.
Okay, I think because of the time limit, and we will close the session in here. I would like to express our sincere appreciation to our three speakers, world well-known scholars, and also I would like to express our sincere appreciation to all the audience. And before the session ended, may I ask the director of the Department of Oral Health and the Ministry of Health and Welfare, Dr. Zhang, to come to the stage to take a photo with us, with the speakers. Yes. Okay.
Welcome.
Hey, can we come to here to take a picture with, yeah. 你卡掉吗？嘿嘿嘿。不，那个，Egusa here. So, take the mask off. Yeah, take the mask off.
Hey, let's take a picture. Yeah. 3, 2, 1. Yay! Thank you so much. Thank you. Once again, thanks to Moderator Shi and all the speakers of Parallel 2A. Thank you so much. Ladies and gentlemen, now we will take a coffee break. Please follow the instruction of our staff to the dining area for snacks. You are also welcome to visit the exhibition booth on the 10th floor. And also, you are welcome to head to room 1101 for plenary 3 and the closing ceremony at 3 o'clock. Kindly remind you that those who stay until the end of the closing ceremony will have a little gift. 好，再次谢谢呢，我们现场所有贵宾热情的参与。那现在我们是中场休息时间，可以呢，请大家依照我们的工作人员指示，到我们的点心区域享用点心。那同时呢，也欢迎您可以到10楼参观我们的展摊。那另外呢，也请大家稍后可以到我们1101哦，去参与我们主会场3，还有呢我们的闭幕典礼将会在3点钟的时候开始。也要提醒您，就是呢，如果您有参加我们的闭幕典礼的话，我们待会也特别准备一个礼物送给您哦。谢谢大家，谢谢。